Thanks, Nilesh. That was a wonderful demonstration of how to avoid complication and what are the best way. So now the forum is open for the question answer. Anybody has any question, please come to microphone, introduce yourself, and quick and short question so that we can utilize this time.
So we'll do
for
the
question
case
answer.
presentation later.
Yeah.
We'll
do the case presentation later. First, we will take the question answer. Okay. So if there is no question from the floor, by the time people, yes, Parag,
ask first. Yeah.
So on the indication part, let me ask all the panelists, what are your correct indication? Do you follow the ISACOS guidelines for indication, or you follow the generalized indication of primary varus in proximal tibia? There are ISACOS guidelines for the indications.
So I would submit to you that because primarily my work is arthroscopy based work, majority of my osteotomies are in conjunction to either a meniscus root tear to offload the repair, where they have onset of OA in the medial compartment, or in cases where there is ligamentous insufficiencies. These are the ones where I do osteotomies.
Okay. Anybody else has a different point of view? Clement?
They are ISACOS guidelines.
Yes.
They are not sacrosanct rules. So you have to decide based on your clinical judgment and investigations.
So you go on more on a clinical judgment rather than the fixed guidelines. Yes, Clement?
Sometimes when you have a dilemma that whether the patient may improve after osteotomy or not, there are a few things I do. One is I keep a lot of offloading braces. Okay. So I'll fit the patient in my clinic and make them walk around for an hour or so, and then get a feedback. If they say they are much relieved, I have much more confidence of offering them osteotomy. And second thing is, a lot of these patients have comorbidities. They have patellofemoral pain. So that also has to be documented. If something has to be done like lateral release or anything, I will note it down then and there.
Yes, Parag, you wanted to have one quick question.
Yeah, I had a question regarding the MCL release. So Mukesh, you said that in your talk that you can transect the superficial MCL also, and what Clement also showed nicely, which was alluded by Nilesh, that you completely release it, go behind. And in the past I have done both, inadvertently because of not knowing. I have transected the MCL, I must admit, but I have not had any issues. And later on, nowadays, I always completely subperiosteally release like Clement showed. But Mukesh, the question to you is it okay to transect, or you should avoid transection of the superficial MCL while doing the HTO?
So that's an excellent question. Literature says it doesn't make any difference, and your experience also says, provided you are right at the level of PES, so that you have at least 3.5 to 4 centimeter intact MCL proximally.
So that goes on to show that the deep MCL is important. So you always protect the deep MCL. But there is so much importance given to the superficial MCL when we talk about total knee replacement. You know, superficial ligament blowout immediately converts a conventional TKR to a constrained TKR and maybe a hinge. So I really don't know this.
So, but when they come for TKR, it's almost about 10 years down the line. Many of them, they come and we see the MCL heals very well by that time.
And in TKR, you release the deep MCL.
And
right?
we just deep. So superficial MCL, even if you release, it heals well. And if you transect, you are not touching that superficial MCL.
So let me ask all the panelists, how many of you transect the MCL?
I don't transect it, I release it all the way. So
no, how many of you transect the MCL? Only Mukesh. How many of the delegates who do HTO transect the MCL?
Raise your hands.
Raise your hands. How many of you transect the MCL? How many of you superficially release the MCL? I think majority of us superficially release the MCL. Maybe because we are a sports injury surgeon, we have a different way of looking at MCL. But a trauma surgeon, all of them, they transect the MCL. Yes?
Yeah, Anil, you want to comment on, you said this much, transection is okay, so do you want to quickly comment?
By the time you release this much, now the way is almost peeled off completely, but it peels off in a layer with periosteum, so it's better to heal. That's what I would say.
Yes, Anil?
The way I think of this issue is that there's multiple ways to expose a hip. There's multiple ways to expose a medial tibial osteotomy. You could do it the way that Clement showed, which is a total knee approach. You can do a more extensile approach, where you do that same approach and then you still cut and make an L flap, so you're really around the knee. You can do the Canadian Fowler approach, where they just make a posterior window and transect the superficial MCL, or you can do the Christian Clay approach where they do a small MCL release and then they release the gastroc. So there's 4 different kind of ways to go in, just like you can go to a total hip from the front, from anterior lateral, from lateral, or the back. And if you want to be a good knee surgeon, you need to know all the different ways to get in there. And and depending on the knee, some knees have some residual MCL laxity, so you'd want to adjust that. And I can tell you, the Christian Clay approach, I forgot someone commented on it, is very I've seen people try to do that and really bucker up the MCL. So there's all different ways to skin a cat.
Yeah. So we'll move on to the next agenda.
No, we have some more questions. So I have a few questions. So I think a lot of importance was given to the JLCA by Clement when he spoke. So my question to Clement is, the JLCA can be, cheated. What is the ideal way to calculate it? We can do a single joint weight bearing, we can do a double stance X-ray. Sometimes, inadvertently your radiologist will give a little strain or the way he positions it. So JLCA can be, quite misleading, the joint line congruence angle. So which is the ideal way to, take the X-ray so as to get the correct measurement of your JLCA?
I prefer to take the bipedal standing view, the scanogram. And as you rightly said, this is one way where you can end up not being very accurate about your preoperative planning. You may plan 8 mm opening, but there could be some space for fine tuning on the table. So on the table, you open, you give an axial pressure, close, and then maybe you want to decrease, you want to increase. You should be ready to play around a little bit in your perioperative opening of your osteotomy, sir.
Okay, so next question to Dr. Bhushan. Bhushan, you gave an excellent talk and you spoke about UKA and HTO. So whenever you do a UKA, just to go a little further on that, do you prefer a mobile bearing uni or do you prefer fixed uni? What is your choice?
Slightly controversial topic, but I have moved from Oxford, so mobile bearing in 2012 to fixed bearing. And last 13 years I've just been doing fixed bearing unis. I feel they are matching in terms of longevity and activity for Oxfords in all the joint registries now. So post 7 years the functions are equally same, the survival is equally same, and I have a gut feeling that they will even surpass the Oxford longevity.
So is it right to say that if your ACL is deficient, then you should still use fixed bearing and not use a mobile bearing, because the Oxford are very, very pertinent?
Oxford are very stringent in terms of their inclusion criteria. A fixed bearing can be done in even deficient ACL with no instability, symptomatic instability in the patient. You can play with the slope in a fixed bearing. So there's a lot of things you can do with fixed bearing. So we can extend the indication significantly in the fixed bearing. That's why I like it. And I feel it's more forgiving as compared to Oxford. So I'm a decent surgeon, I'm not an excellent surgeon. So I'm pretty happy doing a fixed bearing for most of my patients.
Anybody on the panel, fixed versus uni TKR? Clement, Mukesh?
Fixed bearing, sir.
Fixed bearing.
That is the best question for tomorrow. Which bearing? Because I think all of our joint preserving surgeons.
Okay, so I think now question, please, if anybody has questions, come up. We have few minutes.
I have one question
please
from
come. Sunny, you can ask first.
I have one question from the audience perspective. There are a lot of young surgeons over here, to the panel itself. So when you have a young arthritic knee and do a single joint weight bearing X-ray and you see lateral compartment osteophytes, so does that hinder your decision to do an HTO or the further investigations that you would like to do when you do a scanogram, when you do an MRI and other X-rays?
Lateral osteophyte, I think, is not an indication not to do. Joint line tenderness, of course, should give you red flag. Every HTO will undergo pre-op MRI, but then you should be able to read that there are no cartilage erosions and the lateral meniscus is intact on that side.
So let me ask you further to his question. If there's a peripheral lateral meniscus tear, will you repair that tear and do HTO, or you will change your plan?
So less likely, that may be a hypothetical question, to have a peripheral tear with a varus knee because it's already offloading the lateral joint. So less likely to have that, but if it's in red zone, I may go and repair.
So repair and still you can go ahead with this too. Yes?
Sir, myself Dr. Shishir from Bhubaneswar. I have two questions, sir. Regarding that superficial MCL release, so is it, in some of the cases we may encounter that during release, the pes answeriness is coming in my way and that has to be released also. Second question, what about the opening in STO, opening the knee joint, mini open and remove the osteophytes? So that is the two questions.
Osteophytectomy, arthroscopic or open?
No, open.
Open.
Yeah,
Open.
yeah, because, so, first about the MCL, 'cause I always release the PES, I don't suture it back also. As a layer, I release everything and just leave it alone. Whenever I sutured, I found out the patients had slightly more pain. I don't know, because of scarring or irritation, so I leave it alone. So that's not an issue. As long as you don't disturb the deep MCL, that's why you have to be sure about your joint line and where you start your cut below. And about your osteophyte, people, we always start with arthroscopy, then go for osteotomy. So during arthroscopy, there are a lot of things which will help your outcome. One is removal of the notch osteophytes, removal of the anvil osteophytes, treating the mucoid degeneration, debriding the medial meniscus, and also removing this one. And also many times I do an arthroscopic lateral release or arthroscopic lateral partial facetectomy. If there is an overhanging lateral facet of patella, these people will have more pain after STO. Their old pain is gone, but they have a different pain that they aren't able to climb. So in anticipation, I do a little patellofemoral work also.
No, he was asking, do we do something?
Femoral condyle osteophyte, the medial.
All these osteophytes you can do arthroscopically. The problem comes when non-arthroscopic surgeons do, now they have started opening up the joint to do all these things in an open manner. So if you are already doing arthroscopy, I think you should address all the osteophyte issues arthroscopically, then you go for high tibial osteotomy.
So you have to learn arthroscopy for that.
Yes.
So the problem is if you are doing osteophyte excision in the open way, you are going to damage deep MCL significantly. And then if you release MCL, you are going to get a very lax knee on the medial side. So if you are doing it, fantastic, make sure you don't release MCL too much. Take out those osteophytes, and for some reason, osteophytes make wonderful bone graft. If you put the osteophytes in your gap, the gap just fills like fire, so it just heals very fast. So osteophytes can make wonderful bone graft, but be extra cautious when you're opening the joint not to touch the deep MCL.
But I think it's
so
not
if I-
mandatory to
no,
remove
if I
those
heard him-
MCLs, osteophyte. It's not mandatory, so that otherwise everyone will go and start doing
Yes,
it.
that is what I wanted to make a point, Mukesh, to answer his question. If I understood you right, you said the lateral osteophytes. I don't think there is any need to remove them because, those are present, and even while doing an HTO, which is, where you have the medial joint space reduced, these lateral osteophytes can be safely ignored. So don't worry too much about them unless they are too big. Because sometimes they say also one of the contraindications people were saying was lateral joint osteophytes, but the Oxford group, if you see, they ignore the osteophytes in the lateral joint and, go ahead with doing a uni and same as for HTO. So don't worry too much about it. If they're easily seen, then one can
Let me
remove
ask
it.
all the
That's-
panelists, how many of you do closed wedge osteotomy for proximal? For varus correction?
And I asked them, closing wedge tibial osteotomy, and what do you do with the fibula?
So what do you do with fibula, and how many of you do closed wedge osteotomy?
Always medial
Let's
open
start
wedge.
with the panel.
Anybody from panel who does closed wedge osteotomy? Mukesh?
Extremely rarely if he's a,
Rarely, but you do it, right?
yeah, if he's a
So answer that
very young
question.
male and heavy smoker, then close wedge and see that you release the nerve and be careful on lateral side. I
What
don't
about the
touch
fibula?
anything to the
What
fibula.
about the fibula?
No, if it's too big deformity. then
Sir,
you have
is
to-
there anterior knee pain improvement after the HTO? If there are grade 2, grade 3 arthritis and anterior knee pain?
Anterior knee pain arising from where? The patellofemoral joint?
Patellofemoral joint.
Yeah. So there is can there be a small Mackay effect if you do an HTO? Nilesh, is it possible to have a Mackay effect?
In theory, yes, but I think if there is anterior pre-existing knee pain, and I always scope my knees before doing an HTO, if they have those chondral changes, they do have some amount of anterior knee pain. I mean, that's what I've seen in my hands.
Okay.
Yeah, if you're opening more than 12 millimeter, you're going to increase the patellofemoral forces.
No, is there improvement in the tracking? The anterior knee
it,
pain
actually,
improvement?
it may become worse.
It becomes
actually.
worse.
It may become worse.
Patella always likes a varus alignment.
So that is
The
where
moment you
the
bring them to valgus, they are not happy. So that's when you need to do a lateral lengthening, lateral release, or maybe do a distal biplanar osteotomy to change the patella height at the same time.
That's where the planning is very important. As Nilesh has said, failing to plan is planning to fail. And coming back to planning, how many of you use software-based planning? Starting from Nilesh to Clement.
So I do calculate all these not on X-rays but on the iPad using a software either.
You use software.
Yes.
Bhushan, software? Software. How many in the audience use software for planning HTO? I'm very sure many of you are doing.
You should.
Okay.
Yeah,
So
we
there are very few. How many of you have car? Please raise your hand. Are? Everyone has a car. So
No,
please
no,
buy
they
a
have an
software.
aeroplane now. You should
So
ask them.
please, sir, clear me on this point that if there are anterior knee pain with medial condylar arthritis, should we go for the HTO or TKR?
No, anterior knee pain, can I answer that? Anterior knee pain, if you document before the STO, you have to categorize what is the cause of anterior knee pain. There are two broad categories of patellofemoral pain. One group is the excessive lateral pressure syndrome, in which there is a tight lateral retinaculum, there is a overhanging lateral facet of the patella tilt is there, and if you palpate on the lateral facet, they are more painful, and if you do a taping to correct the tilt, they feel better. This is one group of patients in which you can get away adding a lateral retinacular lengthening and a partial lateral facetectomy while you're doing your osteotomy. There's a second group is a global pressure syndrome, GPPS, where the entire patella is overloaded, entire medial facet, everything is kind of uniformly worn out. These are the patients who can't do lateral release and expect you to become all right. For them, you have to do a descending plane high tibial osteotomy, so that you won't at least make the patient worse after your osteotomy. And moreover, whenever you're correcting large corrections, you have the risk of worsening the patellofemoral pain. This is
So there is a syndrome described as excessive lateral patella pressure syndrome. So if you correct it more, there will be excessive lateral patella pressure syndrome. So coming back to the return to the sports. Yes,
I want to say
Anil.
one more question. What percentage of total knees, after total knees, have anterior knee pain? My friend?
What percentage? Yeah, my friend, please.
It's a third. So the total knee doesn't solve your problem. That sounds like someone scared to do osteotomy and thinks total knee is always the answer. Sorry, Dad.
So Dr. Anil, Dr. Anil, I question to you. Do you address patellofemoral issues during your TKR? Because I have seen in the Leon group doing a lot of facetectomies during their knee replacements.
Well, this is a stage for...
So they don't resurface the patella, right?
Yeah, for
They
Amar.
remove a part of the lateral facet during knee replacement.
Yeah, lateral facetectomy has been an old, tried and true way to treat a specific type of lateral overload. But it's true that the patellofemoral joint, there is no great answer. It sucks regardless. If you over-valgulize the knee, it's bad for patellofemoral. You do a total knee, it's bad for patellofemoral. If you do a distal tubercle osteotomy with a opening wedge, you think you're not creating BAHA, still no difference in clinical outcomes and Kujala scores. So the answer is the kneecap is a second-class citizen, understand it, and move on.
Yeah, so I have one last question, after your question.
Coming to the sequence, Bhushan gave a wonderful talk on quality of life after HTO. Bhushan, really in your clinical practice, all your high tibial osteotomy patients are able to return to their pre-injury status, or you predict that this gentleman will go back to his pre-injury status and this won't?
I think with experience you can start predicting these things, but very often than not I'm surprised the level of activity that HTO patients show afterwards, provided you correct them sufficiently. So both under correction and over correction both are bad. So anything above 60%, their pain goes but activity diminishes, and under correction they don't last that long. I think if you hit the sweet spot between 52 and 55, 57%, there's a lateral tibial spine when you assess on table. They're generally able to go back to most of the activities.
Okay, yes, Parag.
So one last question to Nilesh. You spoke about smokers being a red flag.
Right.
So if your patient is a chronic smoker, what do you counsel him? And then do you, purposely reduce the amount of correction? Do you do a closed wedge? Do you graft it from the iliac crest? So how do you tackle? Because if you tell them to stop smoking 1 month before, believe me, they are not going to stop. They are going to even continue later. So how do you tackle smokers when you are considering a HTO?
I think that's where pre-op counseling and discussion is something important. That doesn't mean that I don't do osteotomies in people who are smokers. If the body mass, if all the other criteria are fine, I do talk about incidence of delayed union. I normally don't use a drain. So whatever superclot is formed post-release of the tourniquet, that's something which stays, that's something which helps. I don't know if my colleagues use a drain, but I don't use a drain. And I've had one patient which I showed who had gone into delayed union. I did a bone grafting for him. But if my correction, if it's more than 10 mm, generally I bone graft. If it's less than 10 mm, I don't bone graft.
Okay,
This
let
is
me,
in
let me
smokers.
ask all the panelists, how many of you do bone grafting after medial open wedge osteotomy more than 10 mm? Okay. How many of the delegates do bone grafting after more than 10 mm joint opening or osteotomy opening? Quite a big number. So I think if it is more than 10 mm, theoretically also it's right to put a bone graft so that you can get a better stable fixation. Yes.